السادة الأخوان والأخوات والزملاء الأعزاء، أسعدكم صباحا والسلام عليكم ورحمة الله وبركاته. I would like to share with you a few cases that I have seen in my clinical practice, those who develop this rare complication following hair transplantation. You know that the hair transplantation has recently become the most popular surgical maneuver or method to treat androgenetic alopecia in both male and female. It's based on the idea of what's called donor dominance. That is to say, the hair follicle which is harvested or taken from the occipital area will keep growing when transplanted into the hostile frontal side. This relatively simple technique can be done on the outpatient clinic, but for the optimum result, these are the most important parameters. The patient should be above the age of 25. The diameter of the hair should be more than 70 micron. The density of the hair from the donor side exceeding more than 80. And frontal scalp, the result is better than the other side. And found that those who are blonde hair are preferential to that with black hair. Technique is relatively simple. It's done under local anesthesia. First, we have to harvest or take the graft from the donor side by doing what is called tumescent anesthesia, injecting adrenaline with xylocaine with physiological normal saline into this area, and then we harvest the donor hair. Two techniques are available. The old one is the elliptical donor excision, and the second, which is recently, is the follicular unit extraction using what is called a punch graft. This is the technique of extraction. The punch is a line along the hair shaft and goes down into the hair follicle. Then the harvested side or extracted hair follicle will grasped by a mosquito and then removed from its root. But keep in mind, the patient, you have to not to exceed more than 2,000 or 2,050 follicular units for each treatment, because there is risk of thinning from the donor side. This is the removed follicles kept in the petri dishes with normal saline. And then we have to reimplant this graft into the recipient side. These are the points should be remembered when you are doing implantation. You have to use either small gauge needle or a blade, small blade, to create the incision side. And the incision, of course, depends on the depth of or the length of the hair follicles. And you have to keep you in the safe side. Do not exceed more than 20 to 25 follicular units each square centimeter, and keep a distance of less than or more than 1 millimeter in between the recipient side, and the bulb of the hair should be positioned deep in the subcutaneous tissue. This is the blade used to create an incision in the recipient side. The anesthesia is done on the frontal area at the margin, and then the concentration or the amount decreasing toward the center. Then we have to create the incision in the hairlines. It should be lateral on the frontal hairline, and then it becomes vertical slits afterward. Then we have to grasp the distal portion of the bulb for insertion. Then we insert it in these slits or incisions, and keeping the epidermal portion of the hair follicle outside the surface, and it looks like small dots. This is a perfect process of insertion. Once you complete on one side, you have to go into the other side and insert not more than 1,000 grafts on one side. So once you complete, you have to address the area and prescribing even topical and systemic antibiotic. Okay, what are the, of course, it is a surgery always associated with risk of complications. Fortunately, the complications in this technique is relatively low, but do occur. One of them is the pain, and you know this is especially seen in follicular unit transplantation, and they are easily relieved by giving analgesia, non-steroidal anti-inflammatory drugs. Edema is so common, it's around 40 to 50% of patients develop edema on the site, and is sometimes is descend down to the hair follicle, or sorry, to the orbital area, causing periorbital edema and ecchymosis. Laying down post-operatively the patient, doing massage in the area, and sometimes cold package packs with systemic steroid will relieve the edema. Bleeding, cerebralizing is low, although the scalp is highly vascularized, but the bleeding at this area is, or this surgery is low. Treatment just press on the bleeding site for 15 minutes, enough to stop bleeding. Visible scarring, of course, seen in the donor side. Folliculitis sometimes seen. Graft dislodgement because of trauma, incidental trauma. Postoperative flavum is seen in both sides, the donor and the recipient side, usually occur within 2 to 3 weeks, and regrowth occur 2 to 3 months, 2 months later. Minoxidil could help. Loss of sensation always occur in both sides, and this is temporary. The sensation return back within few months. The recipient site necrosis, or we call it RS, although this is a rare complication, but sometimes do occur. This is very important because it impacts the cosmetic and the physiological and psychological outcome of the patient, but also have a medico-legal implications. Some patients seeking for money or financial compensation. So the surgeon or the physician should know, be familiar with this complication, how to prevent and how to treat. RSN, or recipient site necrosis, is usually occur because of vascular compromise. This is occur usually in the large number of recipient sites or graft implanted in the recipient site, and devascularization because of the dense splitting in the recipient scalp in creating a large wound area. However, there are patient and technical predisposing factors for this complication. Patients who are smoking are at risk. Patients having atrophic skin damage, old age patients with systemic diseases like diabetes or hypertension or atherosclerosis, previous scar in the scalp, are more susceptible to develop this complication. Technical errors or factors include dense backing when you insert more than 20-25 follicular units at each square centimeter, and a distance less than 1 millimeter between the recipient graft. Mega sessions, when you exceed more than 2,000, 500 follicular units each treatment, creating large opening for insertion, more than 4 millimeter. This causes more incisions in the area. Excessive infiltration of tumescent anesthesia with high concentration of adrenaline, and deep recipient incision when you digging inside the skin more than 4 to 5 millimeter, because you will damage the vascularity in the subcutaneous tissue in which the graft depends on for survival. However, scalp contributory factor may have a role. You know that the blood supply or circulation for the scalp is marginal. That is to say, the capillary blood supply or the arteries comes from the periphery. It heavily enriches the periphery of the scalp with blood, however, leaving the central scalp relatively less vascularized than the periphery. Also, the vascularization in the center of the scalp is also jeopardized or affected, also diminished in patients with androgenetic alopecia. How the patient presented? Usually, the patient presented with pain that occur after surgery, and he developed dusky or cyanotic discoloration of the scalp. And if the rescue measures fail, the patient will develop blackish discoloration resulting in eschar formation. This eschar will be dislodged, leaving a large necrotic area which heal with atrophic scalp. So it is very disastrous for the patient. Herein I am reporting 5 cases that I have seen in my practice of recipient site necrosis that happened after a successful hair graft transplantation. The first one is a 45-year-old non-diabetic but heavy smoker presented to me with this large ulcer. The ulcer is located in the central of the scalp. You can see the ulcer is well demarcated, and it located just in the area which corresponds to the anterior fontanelle of the scalp, and it shifted laterally toward the parietal area. This happened 7 days post-operatively. Second case was a 36-year-old man, non-diabetic or a smoker, developed deep ulceration with superadded purulent discharge. There is secondary superadded infection. You can see the ulcer in the central part of the scalp will relatively shift toward the right parietal area. Also started a few days after doing surgery. The third was a 34-old man, non-diabetic or smoker, developed this ulcer, which covered by adherent crust, which removed, leaving this large ulceration 10 days after surgery. This patient is a young man, non-diabetic or heavy smoker, developed this blackish discoloration of the scalp few days after doing hair transplantation. You can see the ulcer is covered by adherent black eschar. This is also the fifth case, 40-year-old young man, non-diabetic or smoker, also presented with deep necrotic ulcer covered by adherent thick blackish crust, which is few days after doing surgery. What can we do here? Actually, if we are facing the patient or seeing the patient, the impending necrosis, the early stage, when the patient having just the cyanotic discoloration, we try to say as much as we possible we can for the graft area by following these maneuvers. We can use topical skincare, topical nitroglycerin solution. This is applied so frequently, every 2 hours over the area, to induce vasodilation in order to enrich the site of the necrosis with the blood in order to save the area as much as we can. Centers who are having hyperbaric oxygen therapy is also of help. This enforces the oxygen into the tissue by a special maneuver or technique, also help to reduce the necrosis. However, when the necrosis is established, in most of cases, the patient develops the black eschar or black discoloration. Here we have to interfere by debridement of the eschar using curate deep into the subcutaneous tissue, leaving the wound area to heal with secondary intention. It takes around 4 to 6 weeks with atrophic scalp. Also instruction the patient to clean the area, frequently using antibiotic topical or systemic regularly, and if he is a smoker, you have to advise him to stop. No more smoking. This is the case number 4. Follow-up for after 2 weeks. I remove the eschar, the scalp, giving antibiotic, local skincare, and the patient, you can see here, after 2 weeks, there is attempt for healing with secondary intention. You can see there is granulation tissue formation, and you have to leave it for heal by secondary intention. After many weeks, months, or years, we can discuss with the patient a follicular regrafting over the scar area. And even in the surrounding tissue or the skin, if it is affected, but here you have to be sure that the density in the reimplantation should be less than the usual, less than 20, and no epinephrine or no adrenaline or even little amount of adrenaline must be used. This is the patient case number 1. This is a big ulcer, and this is the result of reimplantation or retransplantation after this done after 1 or half year after the skin necrosis. You can see complete regrowth or complete successful hair transplant. However, the story is not so like that. It's not always there is happy endings. Point to remember, you have to keep when you are doing hair graft, keep in your mind that the central scalp is more vulnerable for necrosis. Paradoxically, this area needs large amount of high density of the graft to achieve a more natural and dense looking. The patient at risk, you have to use minimal amount of adrenaline or epinephrine in the tumescent solution anesthesia. Physicians should avoid dense packing and stay on the safe side, targeting the area below 30 or 25 follicular unit at each square centimeter, watching the recipient side for any sign of perfusion compromise, such as bluish or cyanotic discoloration, using needles instead of microblades because the sharp tips of the needle pointed in injures the small area of the skin comparison with the blades, which create a rectangular more damage. Minimizing the depth of penetration, do not exceed more than 4 millimeters because the subcutaneous vascularity is very important for the graft survival. In the event of necrosis, of course, you have to debride the necrotic tissue to promote wound healing by secondary intention. With the scar or the alopecia scalp area can be transplanted later on with extra precautions, including less amount of adrenaline, less dense packing, and small needle to minimize the depth of penetration. In conclusion, recipient site necrosis is a rare but well described complication of hair restoration surgery. Second, you have to identify patients who are at increased risk for poor vascularity, such as bending on the medical and physical examination. Intraoperatively, the use of high concentration of adrenaline or epinephrine, high volume of tumescent anesthesia, dense packing in the central and mid scalp should be avoided. Once the area of persistent implantation or cyanosis is noticed, every effort should be taken to minimize the area of necrosis. And once the area of necrosis is delineated, debride the area with the usual wound care standard care. Secondary implant should be discussed with the patient. Before I closing, this is not mine, it's not my patient. This is a courtesy from one of the distinguished colleagues. Look to the catastrophic area of necrosis that affected the whole transplanted scalp. And here the area are left for the secondary intention. Definitely it will end with a scar. And you have no reserve, no bank for hair to retreat hair transplant. So it's very, very, very dangerous complication. And thank you very much for your attention.